Chapter 9, Palliative Care and End-of-Life Care. All right, so what is palliative care? So by definition, palliative care is the treatment or care focusing on reducing the severity of symptoms. So this is typically when a patient is diagnosed with a life-limiting illness. Okay, so life-limiting illness refers to a condition that interferes with the patient's normal activities of daily living. So for example, if a patient isn't able to independently, get up in the morning, go to the bathroom and brush their teeth, wash their face, that would be considered a life-limiting illness. Them doing their everyday routine, maybe taking a few steps out their front door, taking a walk, if that is being affected by this disease, then we consider that life-limiting. Okay, so what is involved with palliative care? So number one, interdisciplinary collaboration. Okay, interdisciplinary collaboration is a little bit different than a multidisciplinary team effort or collaboration. So we'll go into that in a moment. So communication with patient and family, again, this includes the patient and their family with the plan of care. So for example, if you have a child or an infant, we'll say a 6-month-old baby diagnosed with cancer. So it is at that time that palliative care would come on board to support the baby and also the family. Okay, so it doesn't matter what age. Palliative care can be any age. Care in multiple settings, so this can take place in the hospital, it can take place at an assisted living, at a skilled nursing facility, at home, anywhere where the patient lives. So important to remember is that palliative care begins during curative health care. So the patient is still getting treatment for their condition or disease. They're actively getting treated for it. So with palliative care, that does not stop. Okay, very important that you remember that. So for example, if a patient who has renal failure, those patients will still continue to get dialysis. If a patient has cancer, they're still going to continue to get chemotherapy. And that heart failure patient will still continue to take those meds to treat the heart failure. Okay, so palliative care still maintains curative treatment, curative health care. Now, once the patient begins to decline towards end of life, then palliative care will also help support the patient and the family during that time. So when palliative care transitions into, comfort care instead of curative care, they don't get rid of palliative care. They're not discharged. They don't stop it. It continues on through that transition. And then also after death, it continues on into the bereavement period. Okay, so once the patient has died, palliative care will continue on to support the family after their death with whatever needs they need and whatever resources that we can give them. So the goal for palliative care is to prevent and relieve suffering. So how you need to interpret that is you really want to get a good idea of what the patient's goals are, how they want to live once they have been diagnosed with this life-limiting disease. What are their individual goals? And we want them comfortable. So with this comes with those as-needed PRN medications and also other non-pharmacological approaches, especially to pain, mobility, those type of things. So maybe they can use, if they have a joint problem, we can encourage like physical therapy, some low stress exercises, or non-pharmacological things like a warm bath or a cool or warm compresses, stuff like that. So not always medication driven, but certainly if we have medications to keep them from suffering, let's get them access to it. And then overall, we just want to improve the quality of life for the patient with a serious life-limiting illness. Okay, so this next slide kind of goes over what I just mentioned in the previous slide. So again, palliative care is available to everyone, doesn't matter what age, as long as they've been diagnosed with some type of serious and life-threatening condition. So this is, again, going to involve comprehensive symptom management. So what that means is we're going to anticipate their needs. We're going to find out what their individual needs are so that we can provide the appropriate care for that. They may continue curative treatment. Okay, we talked about that. All right, so what is interdisciplinary collaboration? So we're all familiar in the hospital with all the disciplines that are available to us or to the patient, and we all kind of work together in the hospital. So what's the difference between that setting and the palliative care setting? So in the hospital, we have a team. We have physicians, we have nurses, we have respiratory therapists, physical therapists, occupational therapists, we have dietitians, we have all of those different disciplines working together. The difference is the plan of care and the goal is more patient-centered and family-centered with palliative care. So for example, and I use this example in class, so this is deja vu, it's going to be again repeated. Okay, so the example is a patient comes into the hospital and maybe they fell at home. They come into the hospital, they're ready to be discharged, so the doctor orders a physical therapy evaluation. The PT comes, does your evaluation, they document it in the computer, the doctor reads the evaluation, and the physical therapist writes, patient able to walk 10 feet with walker without becoming short of breath. Okay, so the doctor interprets that as in good. The patient can be discharged, patient can independently walk with a walker 10, 20 feet, they're good to go. Okay, and then the patient's sent home, but it kind of stops there. So with palliative care, the difference is the physical therapist is going to sit down with the patient and the family to see what exactly is going on at home, wherever the patient resides, and how we can tailor the physical therapy and their needs specific to that situation. So maybe sure, the patient is okay to walk 20 feet with the walker without short of breath, but what else in their life do they want to do, or do they want to get strong enough to do that would make them have a better quality of life? So maybe the patient wants to walk around the block or walk, up the street, or maybe there's some stairs that they would like to go up, stuff like that. So it's more patient and family centered to their individual needs. So it's the same disciplines, it's just the focus is more specific to the patient, right? Okay, palliative care also supports the family psychosocially. So having a sick loved one, it brings a lot of stress, it can bring anger, anxiety, all kinds of emotions. So supporting the patient and the family during this time can really, really help give the patient a better quality of life and ease caregiver burden. Spiritual support. So spiritual support is not necessarily religious, okay? Everybody has some type of spirituality. It goes along with the question, if you've ever wondered what happens after you die, that's kind of your spirituality. Whatever you believe in, it does not matter. It's not necessarily culturally tied or religion tied. It's just these type of things tend to come up when you're very sick or when you're close to end of life, because the end is near and we want to provide support. It can be scary for both the patient and family. And then palliative care also provides respite care for the caregivers. So respite care is just kind of like a break, some time for them to kind of take away from taking care of their loved one. So again, in class, I mentioned an example about a patient who was hospitalized, who's a total care patient living at home with the daughter. The daughter needed a break. She didn't want to send her mom to permanently be at a facility, but she just needed a break. So insurance has a palliative care benefit. They were able to place the patient in a skilled nursing facility for about 2 weeks while the daughter was able to take a break. So again, that is a benefit of palliative care. It's paid for by the insurance under the palliative care benefit. Again, with palliative care, the goal is to improve the patient's and the family's quality of life. This is a short little case study just to give you an idea of a patient who you will see in the hospital many, many times if you work in the Med-Surg or telemetry or even in the ICU setting. So palliative care in action, a case study, Michael's story. So I'm going to go through this kind of quick, okay? So just read through it also on your own if you'd like. All right, so Michael is a 75-year-old male with advanced COPD, pulmonary hypertension. disabling shortness of breath. Okay, this is his second hospitalization in the last 2 months. So that is quite significant because our goals are to keep patients out of the hospital. All right, so here he is in the hospital for the second time. Palliative care consult was ordered. His goals are to improve his ability to walk, transfer, and care for himself. His wife is with him. She's tearful, anxious, just about the whole situation. So before palliative care, he had increased shortness of breath, limiting his mobility. If any of you have had asthma or seen somebody with asthma, it's not a good feeling not being able to breathe, okay? It makes you scared, fearful, gives you anxiety. You don't want that feeling, so you don't want to do anything. You don't want to leave the house. You don't want to walk. So that is definitely a condition that interferes with his ADLs. Okay, so he hasn't been outside in 2 months. He's very fearful. He has polypharmacy, which means he's taking several medications. Hospitalized 4 times in the last 2 years. Also been intubated twice. Okay, poor quality of life due to shortness of breath, and the wife is obviously exhausted and overwhelmed. Okay, so during palliative care, there's lots of meetings held with the family and the patient to really see what the patient's realistic goals are and then to match it with realistic treatment options. So in this case, Michael was started on a low dose of morphine, okay, liquid morphine, and this is PRN, shortness of breath, and to be used 30 minutes before going outside. Patient's wife also says that he has an inaccessible bathroom and bedroom is on the 2nd floor. So this patient upon discharge was referred to a home-based palliative care team. After palliative care, the shortness of breath and anxiety improved with the use of that occasional morphine. They made some modifications at home, grab bars, elevated toilet seat, an inclinator, that's to help him go up the stairs. And he's able to transfer independently and manage his own ADLs. And if there is ever a concern, they do have access to palliative care team by phone 24 hours a day. Really important. What if something happened at 2 in the morning, his wife gets scared, instead of just calling 911 or taking him to the emergency room, she can call this number and get advice over the phone. So that is also really important, having that resource, having that real-time support, real life person giving you support over the phone to avoid more hospitalizations. And then no emergency room visits or hospitalizations over the next 6 months. So that is a good thing, not only for the patient and his well-being, but also because it keeps the hospital happy. You know, they just saved money, essentially. Remember, hospitals, they are a business. Okay, moving on to palliative care at end of life. So all of us are going to die at some point. We are all going to enter this end of life transition at some point. So right now we have an increasing demand of palliative care at end of life because we're going to have this influx that we're going through actually as we speak of older adults. And these older adults are living longer. They're living longer with chronic diseases. So it's really important that 1, we understand how to treat these patients, and 2, we're expecting this to come, so we need to be prepared. So these are the baby boomers. These are the people who were born after World War II. Many people were having lots and lots of babies. Well, these babies are getting older, and they're going to need medical care. All right, so palliative care overall, again, it improves quality of life. It reduces healthcare costs, and it eases caregiver burden. So it's pros all around. Okay, so now we're going to talk about hospice. So all of hospice falls under palliative care, but not all palliative care is hospice. Okay, so hospice is a piece of palliative care. And the major difference between the two is that hospice, you no longer have curative treatment. So the examples I gave earlier, that renal failure patient, so that patient will no longer get dialysis. Okay, the cancer patient will no longer get chemo, and that heart failure patient will no longer take their medications for their heart failure. So that is the biggest difference between palliative care and hospice. With hospice, again, this is a benefit that it comes with insurance, so you have to be eligible for hospice. So one, the patient has to be able to want to go on hospice. You can't force somebody who is alert-oriented to go on hospice. And this is done in writing, okay, a legal document. And then the patient must be medically eligible for services. So 2 physicians must certify that they indeed have a terminal illness with less than 6 months to live. Okay, so that's very important, very specific. All right, so that's hospice eligibility. The goals, though, are very similar. We want these patients to live fully and comfortably and to die with dignity. The die with dignity part is specific to the patient. So however they feel, if they're still able to express how they want to die, then we should follow those, what they want to do. So hospice, again, is very, very similar to palliative care. Still going to offer that symptom management. We're also going to throw in their advanced care planning, because with hospice, they have a terminal disease, terminal condition. So we are anticipating their death. So we want to start preparing everything before that happens, because that makes it easier for everybody. So that includes advanced care planning, which we'll talk about, spiritual care, family support, again, comfort care rather than curative, and quality rather than quantity. So we're not trying to keep them alive longer, but instead we want them to have quality of life. We don't want them to suffer. And here we're going to talk about the lack of inaccurate information. So many people, unless they have had a loved one on hospice, don't really know the details of hospice. So what they think in their mind, it can differ from what reality is. So this is common with cultural and ethnic groups. They sometimes feel uncomfortable having someone else outside of their culture coming in to take care of their loved one. Okay, physicians and other providers may be reluctant to recommend hospice services, because they may feel like they themselves are giving up on the patient. They did something wrong, or they weren't able to cure the patient, something like that. It's kind of like an ego trip. And then patients and families feel like once they place their loved one on hospice, they'll be forgotten. They're not going to get the quality care if they're on hospice. So there's a lot of misconceptions. And then there's also potential barriers to care in vulnerable populations, such as the homeless, their socioeconomic level, and if they're institutionalized, like in prisons or jails, that type of thing. Okay, so hospice care is holistic care provided by medically supervised professional teams and volunteers. Again, we're going to have that whole multidisciplinary team. We say inter because they're intertwined. We're all focused on that patient's specific wants and goals. So hospice nurses, we help to control the pain, the symptoms. We continuously assess their spirituality to see if they need support in that area. And we're also assessing and managing the family needs. So if you are a hospice nurse, that will entail making home visits, assessments, and recommendations. When the patient is unstable, maybe they're having some type of exacerbation, or maybe they're very close to end of life, then you will provide support care. We want to educate the family on the normal expected dying process, because families get scared, people get scared, and the more education they have about it, hopefully that can relieve some of their stress and anxiety. We do want to teach them about the medications that are available to help keep their loved one comfortable. And then we want to support them after the patient has passed. So this chart just shows the difference overall between palliative care and hospice care. This is not from your textbook, but you can see with palliative care is curative, hospice care is comfort. Palliative care, you don't need a life expectancy. However, with hospice, it's 6 months or less. Both have this very similar. So with palliative care, manages symptoms and assists with advanced care planning while receiving aggressive invasive treatment, right? With hospice care, we manage symptoms and help family transition with the end-of-life care. And then with palliative care, they still keep their primary doctor. But with hospice care, they no longer are seen by their primary doctor, but instead it's part of the hospice agency. So their whole team is kind of shifted. Moving on to death. So death, by definition, death occurs when all vital organs and body systems cease to function, and there is irreversible cessation of cardiovascular, respiratory, and brain function. Okay, so that is the definition of death. Brain death. All right, according to the American Academy of Neurology guidelines, brain death is when the patient is in a coma or is unresponsive. There is an absence of brainstem reflexes, and there is apnea. So apnea is periods of not breathing. So this assessment of determining whether the patient is brain dead is typically done by a neurologist. Okay, and it's really important because we think of the patient being older, end of life, but actually, if you like this picture shows, patients can be very young too. It's not necessarily due to a disease or chronic condition. It can be from a car accident, a teenager. So this is a very sensitive subject. If any of you have ever had a loved one, a close friend, a family member, it is a very delicate situation. All right, so what we consider end of life is when we know death is imminent, meaning we know it's coming, nothing we can do can prolong it or reverse it. Okay, death is coming very soon. The period of time varies, even though we know patterns and lots of research has been done, we can kind of like see those telltale signs that death is approaching. We do not know the date, we don't know the time. Those are questions that the family will inevitably ask you. How much time is left? A safe answer would be we don't know, we can't tell, but we're looking at signs and some different signs which can tell us that it's coming near, but that's about all we can say. All right, so end of life goals. We definitely want them to be comfortable, and we want to provide supportive care. Okay, so comfortable and supportive care. We want to improve the quality of the remaining life, whether it's 1 day, 2 days, hours. Anytime that they're still with us, we should be trying to make them as comfortable as possible. We want to help ensure dignified death. That's where advanced planning comes in to see what they want, what their wants are at end of life. And then we're also providing support to the family. So now we're going to talk about those clinical manifestations that happen at end of life, all of the changes that we see in our body. So overall metabolism is decreased. Okay, the body is going to gradually slow down until all function ends. So really what's happening is complete organ failure. All organs are going to die, and as they decrease their function, those are the manifestations we start to see. Respiratory changes are very common at end of life. It doesn't matter what disease brought them here, what condition, why they're dying, but respiratory changes occur very often, almost with every single patient. Okay, so please review table 9.2 in your textbook. Okay, starting with physical manifestations of the respiratory system. So irregular breathing. Eventually these patients are not going to be able to clear their secretions, or they're not going to be able to cough strong anyway. They may have a weak cough or no cough. So this is going to result in lots of secretions kind of building up, and you can kind of hear it bouncing around in there. So you can hear grunting, gurgling, noisy or wet congested breathing, and we call that the death rattle. Then we have Cheyne-Stokes respiration. This is an abnormal breathing pattern. Nothing about it is normal, okay? And this is when the breathing alternates between apnea and deep, rapid breaths. Okay, again, nothing is normal about Cheyne-Stokes respiration. Okay, and here's the example of a death rattle. Okay, and this is an example of Cheyne-Stokes breathing, so just pay attention to the diaphragm. So you can see right here, fast, rapid breaths, slows down, periods of apnea. Okay, so just one thing to mention with Cheyne-Stokes breathing. So this cycle of breathing with these fast, rapid breaths and then these periods of apnea, each cycle is damaging the heart itself, the heart muscle. It's being deprived of oxygen. So as the patient continues on like this, the heart is just becoming weaker and weaker. So also, Cheyne-Stokes breathing does not happen to every patient at end of life. It is usually more common with patients who have had a heart problem, a heart condition, like if they have severe cardiomyopathy or if they've had heart failure and it's very severe, then they are going to be more prone to this type of breathing at end of life, but it doesn't happen with everybody. Okay, moving on to physical manifestations of the sensory system. So hearing and touch, they say that hearing is the last sense to disappear. That's why you'll often hear people telling families to keep talking to them, keep talking to their patient, they can still hear you. But has that been confirmed necessarily? We don't know. All right, so decreased sensation, decreased perception of pain and touch. Sight-wise, their vision can become blurry. They'll lose their blink reflex, which means if you get too close to their eyes, they won't flinch. You know, their eyes won't blink in response. Patient may appear to stare, and their eyelids may not close completely. Taste and smell will become decreased, so they probably won't be too interested in eating. And what we have in this picture here is modeling of the skin. So modeling of the skin is common before death, and it usually occurs during the final week or so before the patient dies. This is not a rule. They can develop this maybe even a couple weeks before, but generally speaking, it is very close to the time of death. So this is caused by the heart no longer being able to pump blood effectively. And the blood pressure will drop from this, and it causes changes in the skin, and the extremities will also feel cool to the touch. Okay, so more changes in the skin. So modeling, hands, feet, arms, and legs, cold, clammy skin, cyanosis of the nose, nail beds, and knees, wax-like skin when very near death. All right, so the urinary system. So decreased urinary output, and that makes sense because we're having organ failure. The kidneys are no longer able to excrete urine. They may become incontinent of urine. That might be related to the nerves kind of becoming impaired also. Or they may not be able to urinate. So this is one of the very few times it may be appropriate to insert an indwelling urinary catheter. If the patient is retaining urine, not able to void on their own, and they're very close to end of life, then we may just place that catheter for comfort. Okay. In the GI system, again, everything is slowing down. Okay, so with the GI system, in the whole scheme of all of our organs, it is a very low priority organ. Okay, when the body senses something's wrong, something's happening, we prioritize our brain, our heart, and our lungs. Everything else kind of, goes on the back burner. So the GI system, if something's going on, it's usually one of the first to slow down. So the GI system may not even function at all. And whenever we don't have a GI system that has peristalsis, that's moving, then we can have buildup of gas. Okay, this gas can cause abdominal distension. It can make the patient nauseated. It can cause vomiting. These patients might also lose sphincter control. And then a bowel movement may happen right before death or right at the time of death. Musculoskeletal system. So these patients will gradually lose the ability to move. They won't even be able to hold themselves up, so you may need to prop them up in bed with pillows. They're going to lose muscle function. So you can see this in their face, sagging of the jaw. They may have slurred speech. They can lose their gag reflex. And swallowing can become more and more difficult. They're at high risk for aspiration. So between these changes, along with the GI changes, these patients really shouldn't be eating, okay? All right, so now we're looking at the cardiovascular system. So as end of life comes closer and closer, the heart is really trying to compensate, and it's trying to keep us alive. But the heart muscle itself is oxygen deprived, just like every other organ. So it's going to try to compensate by beating faster. We're going to have an increased heart rate. Later, as the heart just cannot compensate and it becomes tired itself, then it's going to start slowing down, and then you're going to start also assessing a weak pulse. Okay, so at first the heart's really fast. Closer to end of life, the heart rate will slow and you'll have a weakening of the pulse. This can cause also dysrhythmias, just irregular rhythms due to that hypoxemia, decreased blood pressure, and also because that circulation just isn't happening, there's going to be delayed absorption of IM or subcutaneous medications, which is one of the reasons why we don't administer those type of meds. The other reason is because it can be painful. We don't want to poke patients if we don't have to, but also it's not going to be that effective even if we did give it to them. Some psychosocial manifestations at end of life. So these patients can have altered decision making, anxiety, fear. They can start reviewing their life. They may become very peaceful. They may start saying goodbyes. They may express feelings of helplessness. They can become restless, withdrawn, all of those types of emotions. So at end of life, we are going to expect all of these changes to happen. And since our goal is to keep the patient as comfortable as possible, we're going to use medications to keep them comfortable. So let's see. So pain-wise, we're going to use long-lasting narcotics. We can also do non-pharm things like massage, music, aromatherapy, whatever makes them comfortable, whatever they want. For shortness of breath, we have liquid morphine, usually given sublingually. We can give oxygen via nasal cannula. Okay, when we give oxygen this way, it is for comfort. We don't consider that curative. And then we want to avoid deep suctioning. So if you remember, they're going to lose their ability to clear secretions. They're going to be kind of gurgling. You'll hear those wet, congested breathing. So if this patient were in the hospital, and if they were not on hospice, we would definitely want to deep suction those patients. And that would involve inserting a catheter through their nose all the way down and suctioning out all of those, secretions. As you can imagine, that is quite uncomfortable. You can cause bleeding. It can be painful. And really, those secretions that are in there, they're not hurting the patient. So with these patients at end of life, we are going to avoid deep suctioning. We can give scopolamine patch, usually transdermally behind the ear, to help decrease those secretions. At end of life, it's very common patients will become restless and agitated, so we can give lorazepam or Haldol. Nausea and vomiting, we will give compazine. We can give this per rectum or by mouth. And very common, these patients will become incontinent, so we do want to keep them clean and dry. And again, if this becomes a problem, we do want to insert a indwelling urinary catheter. So with organ failure, there's going to be decreased metabolic function just generally from head to toe, and they're going to experience anorexia, so loss of appetite. They're not going to be hungry, so we don't want them to forcibly eat or drink. So families will often get concerned, like, oh, my loved one hasn't drank anything in 3 days, can we give them something to drink? But we want to educate them on the normal dying process, and they're not thirsty, they're not hungry. This is just the way that the body, this is just the process that humans go through. And then we also want to make sure the patient is positioned comfortably, especially since they're going to have some respiratory changes. Have the head of the bed up and put pillows, to prop them up, because they won't be able to keep themselves up when they're so close to end of life. And then please review table 9.8 in your textbook. Okay, so when the patient has passed, there is a period called bereavement. So I'm sure you're all familiar with the word bereavement and the word grief. So bereavement refers to a time period, okay, and grief is the actual reaction to the loss of the loved one. Okay, so again, bereavement is the period of time following the death of the person. Okay, it involves attachment, anticipation of loss. Grief is experienced and mourning occurs during bereavement. All right, so then let's talk about grief. So grief is a psychological response, and everybody grieves differently. It can include anger, guilt, anxiety, sadness, depression, and despair. All kinds of emotions happen. If you've ever lost somebody, it can be very taxing on you emotionally. Physiologic responses can also happen. Grief can make you have sleeping problems. You could either be sleeping too much or not sleeping at all. It can have changes in appetite for the person. They can be eating everything or not eating at all. It can also make you physically sick. Okay, so if you have just so much grief, it can actually make you sick. It can lower your immune response. So there are several different models of grief. In your textbook, it mentions 2. I'm only mentioning 1. Okay, please refer to table 9.4, the Kubler-Ross model of grief. So according to this model, we all go through these stages, and you can see denial, anger, bargaining, depression, and acceptance. If you look at this table here, you can see a little description of each. So if you're going to be tested, it's going to be tested on this model, not the other model that's mentioned in your textbook. All right, so influencing factors of grief. So there's a lot of things that influence how we grieve, and it's individual to the person. So for example, your personality, how you are mentally, and your physical health. Maybe economic resources, maybe your loved one died and you're the only person around and you can't afford the funeral, so that kind of thing can affect the way you grieve. Your culture, your religion, how much support you have, how long you've known the person, or what type of relationship you've had with them. Maybe you didn't like them, maybe you did like them. And then how much time you spent preparing for the death. So there's a difference if, for example, you found out your significant other died today versus the person was in the hospital for months and months and months. So all of those things can influence the way we grieve. So there's 3 types of grief: anticipatory, adaptive, and prolonged. Anticipatory begins before the patient dies, right? We're anticipating the death. We have adaptive, and that's when we start to accept the reality of death. Okay, so anticipatory and adaptive, those are all healthy responses. Prolonged is what we're trying to avoid. So prolonged is intense mourning for greater than 6 months. So when somebody has a loss and it's been over 6 months and they still have this intense mourning, that's when it's going to start affecting that person's normal daily living. It's going to affect their social life, their work life, their mental health. Okay, so that's what we want to try to avoid and support them through this. During the end of life, and actually anytime we care for a patient, doesn't matter if they're at end of life, we need to be culturally competent. So that means that we understand that everyone has a different belief system, and it is not in our place to be judgmental or to provide different care because we don't agree with them. So we need to understand that cultural beliefs affect the way that people react to death or loss, and it can also affect decisions, medical decisions, whether they use palliative care, hospice. There might be some rituals associated with end of life. So we need to understand that and not judge, and accommodate all of their cultural beliefs as much as we can. So then we go into legal and ethical issues. Again, lots of drama can be stirred up when someone dies. That's why it's really important that if the patient is able to, if they're alert and oriented and able to create these legal documents before they lose their capacity to make decisions, that is the best thing. That way, everybody knows without a doubt what the patient wants and there will be no discrepancies. Okay, so decisions are based on the wishes and values of the patient and their family. We want to make sure the patient does have decisional capacity. So if the patient has dementia and they're advanced, we obviously can't have them making those type of decisions. If applicable, the patient can be considered for organ tissue donation. Advance directive, that's a legal document that patient can sign appointing someone to make decisions related to health on their behalf. And we'll talk about more of that in a second. Do not resuscitate, durable power of attorney for healthcare, living will, and a post. Okay, so there's all different types of things. The main goal here is to get something in place before the patient is no longer to make decisions. And if they are already, incapacitated, once the patient is considered terminal, we want to start having these conversations so that the patient's family or loved ones don't have to think about this. So when the end of life comes, everything's taken care of. So a post. So many of you who work in the medical field already might be familiar with the post. So patients who have a lot of health issues, typically those that reside in a skilled nursing facility or subacute facility, will have a post. It's very detailed. You can zoom in and check this out. The doctor usually will talk to the family, or two doctors can fill this out if there's no family involved, and it really gives detailed instructions on what to happen, on what to do when something happens, some type of critical change of condition. So a little bit about organ and tissue donation. So not everybody is eligible or meets a criteria for organ or tissue donation. It just depends. So here you can see that pretty much any part of the body can be donated. We do need permission. Hopefully the patient themselves have given permission before they died, or whoever is appointed as a decision maker can do that after death. So we do want to document their wishes. We need to follow legal guidelines, of course, and then we want to follow your facility's policies of what to do when the time comes. Okay, euthanasia, we don't do this as nurses. The definition of euthanasia is deliberate act of hastening death. So you are doing something to make the patient die. According to the American Nurse Association, nurses should not participate in active euthanasia. However, physician-assisted suicide is something that is legal in some states in the United States. California does allow physician-assisted suicide. So with this one, the physician, reviews the patient. It's not just anybody can come up and ask for this. They do have to meet a criteria. There are certain eligibility requirements, and the patient still needs to be deemed with less than 6 months to live. So with this one, the patient needs to be able to self-administer the medication. So the physician will provide the medication. Patient needs to be able to take it. So that's physician-assisted suicide. Okay, psychosocial care is very important at end of life and after death. There's a lot of different emotions. Okay, we talked about this a little bit: anger, hopelessness, powerless, anxiety, depression, fear, communication issues. So you can see in this picture who is the patient. It could be the one sitting, it could be the one laying, we don't know. So all of these emotions, we want to provide support. And so what is your role of the nurse? So as a nurse, we're obligated to provide timely, humane, comprehensive, and compassionate end-of-life care. Okay, that pretty much sums it up. We want to relieve suffering, and we do want to use opioids. So some families kind of get a little hesitant or nervous when we start offering opioids because they have misunderstanding, fears about maybe addiction. I mean, addiction is not a concern at end of life. And then we need to be aware of this principle of double effect. So as you know, we just said we as nurses, we don't euthanize patients. Okay, we don't give them medication to make them die faster. We don't do that. However, there is an understanding that when we administer certain type of medications, it may have that effect. However, the principle of double effect means that we're not doing it with that intention. So if you have a patient that is in severe pain, severe pain, they're moaning, they're restless, they're having a hard time breathing, we can give them morphine. But we know that morphine is going to, for example, decrease their respiration, and this patient's already very weak, so that may make them, get so weak that they could stop breathing. However, it is relieving their suffering. So that is a principle of double effect. So your assessment at end of life, so it really just depends on where the patient is at end of life. Okay, so if the patient is alert, then you still want to do your basic review of body symptoms. We're going to assess for discomfort and pain, nausea, shortness of breath, because we already know those are the typical manifestations that we're going to see. So that's what we want to look for. We want to assess their stage of decline. So are they still drinking? Are they eating? How are they sleeping? How are they coping? And then we also want to include the family's ability to cope with the situation and what they need, as support. And then we want to focus on changes related to the terminal illness. So if the patient has heart failure, we're going to do a focus assessment on the heart so we see what's going on there. So stability determines the frequency of assessment and documentation. So if the patient is pretty stable, they're not having any major issues, then, the nurse doesn't need to check on them quite as often. If the patient's in the hospital and they're actively dying, then generally speaking, we check on them every 8 hours or so. If the patient is at home, we go once a week. And then if the patient's condition changes, then of course we're going to assess them more frequently. Once the patient is approaching death, we're going to check their neural status, we're going to check circulation, their pulses, their capillary refill. We're going to see how they're breathing, are their kidneys still producing urine, and do they have bowel sounds? And we're going to check the skin. At this time, again, skin is an organ. It's going to start to fail too, so these patients will develop wounds much faster than your typical sick patient in the hospital. And then once the final hours approach, we really don't want to overstimulate them. We want to give them privacy with their family. It's going to be comfort measures only, and we just want to make sure they're not in pain and they're breathing okay. So that is when you want to take the cues of the family and ask them what they need. Sometimes they do want you present. Sometimes, they just want to be left alone. So that is something you need to assess. So nursing management overall. So psychosocial and physical care are interrelated because, like we mentioned, you can make yourself sick by grief. It is important that we always provide education on the disease itself, anticipate the physical changes that are going to happen as a patient transitions to end of life, coping strategies, and denial and grieving may be barriers to learning. So what that means is if you have a family member or even a patient who just has not accepted the death, okay, or maybe the patient has died and they still have an intense grief, and they're still intensely grieving. These patients, you're not really going to be able to talk to them to teach them something because their mind is not ready, their readiness for learning is not there. So we have to assess that also. And then for you as the nurse, if you work in ICU, you're going to see a lot of death. In the ER, you can see a lot of death. You see death everywhere in nursing, but in hospice, if you're a hospice nurse, obviously you're going to see a lot of dying patients. So it is challenging, but it can be very rewarding. If you're not comfortable around death, this may not be a good setting for you. You first need to recognize your own values, your attitudes, and feeling about death. If you have strong feelings and you're very emotionally driven, this may not be the right setting for you. So be very self-aware. And if you are a hospice nurse, you have to make sure to take care of yourself and, make sure you have your own support system. And that concludes this chapter.
Hey, is this Georgia? Yeah, sudden cardiac arrest.
No.
We're getting her back. We have to.
Well, how long has it been?
42 minutes.
Oh.
What are you doing?
We have to call it.
No, she's not. They can't have another funeral.
Amelia, she's gone.
Damn it.
Time of death, 14:02.
You need something?
No.